Good morning, good afternoon, and good evening, wherever you are in the world. I want to wish all of you a very healthy and happy New Year. I'm Aaron David Miller, a senior fellow at the Carnegie Endowment for International Peace, and welcome to Carnegie Connects, a set of virtual discussions on issues of critical importance to America and to the world. Today's discussion is on COVID-19 and the challenges we face in the new year and beyond. But I'd be remiss, frankly, if I didn't say a word about what played out in this city yesterday. What we saw yesterday, the abdication, in my judgment, of real leadership by a president, the triumph of the personal over the national interest, and the courting of irrational and extremist forces denying reality and, of course, denying science, have only worsened the gravest public health crisis that this nation has faced in a century. When I asked John Barry, some time ago, the author of The Great Influenza, actually on this program, what was the most important takeaway and lesson from the Great Influenza of 1918? He replied, governments in a crisis must tell the truth, not manage it, distort nothing, put the best face on nothing, manipulate no one. It's all about public trust, pulling together in the face of this extraordinary crisis. Enough said. In April, which now seems like years ago, when we first took up COVID on this program, it was clear even then that this pandemic was much more than a passing headline. It may well be viewed on reflection and in the rearview mirror as the most world-altering event since the Second World War, and it has already altered that world as we know it. For how long it may do so, we don't know. But 2020 has now given way to 2021. The virus continues to exact a terrible toll, but there's also greater possibility than ever before. A new year, new vaccines, new U.S. leadership, and new hopes to conquer COVID. So what is the new year going to bring? Where are we in the COVID arc and trajectory of the race between a surging disease burden, our effort to control it, and the race to distribute a vaccine? How do we explain the slow and poorly coordinated rollout of that vaccine? And what's required to fix it? What's the right balance between federal responsibilities and those that accrue to the states? What do we make of all of this talk and action in Britain regarding adjusting the dosing in order to cover more arms or lengthening the time between vaccinations? And what of this new variant or mutation? How serious is it, and can we track it? What can we learn from other countries who have perhaps been more successful in coping with COVID than we have? And how do we deal with the challenge of inequitable global distribution of vaccines, what you could call vaccine nationalism? Finally, although nobody wants to focus on it now, what do we do in the midst of a pandemic in an effort to prepare for the next one? Infectious diseases kill more humans on this planet than anything else. And 2/3 of the newly discovered pathogens in this world are viruses. Fortunately, these are very complicated questions, unfortunately. And fortunately, I don't have to answer them. We have three extraordinarily talented specialists, three doctors, who can afford us both the view from 30,000 feet and the granular. Dr. Celine Gounder is a practicing HIV infectious disease specialist and internist, as well as an epidemiologist. She's also CEO and president and founder of Just Human Productions, a nonprofit multimedia organization, and the host and producer of American Diagnosis, as well as Epidemic, a podcast about the coronavirus. Dr. Maria van Kerkhove is an infectious disease epidemiologist, world-renowned, and the COVID-19 technical lead at the World Health Organization. And finally, Dr. Leana Wen is an emergency physician and visiting professor of health policy and management at GW University School of Public Health. She's an expert in public health preparedness and previously served as Baltimore's health commissioner. She's a contributing columnist for the Washington Post and an on-air commentary for CNN. Format is quite simple: 5 minutes from each of our panelists, a moderated round of annoying questions from me, and then questions from the audience. So I think we'll begin with Dr. Gounder. Let me turn the virtual floor over to you.
Thank you, Aaron. And I just also want to add that I am on the Biden-Harris Transition Coronavirus Advisory Board. However, all of my comments here represent my own perspective, unless I specifically say that I'm speaking on behalf of the board. I think in terms of the problems we're facing with vaccine rollout, and my comments here will be more specific to the United States situation, I think of this in a couple different ways. One of which is this a supply problem? Is this a distribution problem? Or is this a demand problem? And I think which of those areas of bottleneck will shift over the course of vaccine rollout. So right now we have this phased approach to distributing the vaccine, in part because there is a shortage relative to the size of the overall population. But given how we've decided to phase in vaccination, so phase 1A being the long-term care facilities and healthcare workers, we do have the doses we need to reach those populations. So it's really a distribution challenge that we're facing right now more than anything. But I actually do think in the coming weeks, the phase 1A rollout, a lot of those kinks will get themselves worked out. The one group within that we are still a bit concerned about are the hesitant healthcare workers, which is probably about 25%, maybe 30% of healthcare workers who kind of want to wait and see. They want to wait on the sidelines, see how it goes, see how others fare with the vaccine. Do they have side effects? And many of those more hesitant healthcare workers are also healthcare workers who are from communities of color or from the more partisan right wing of the Republican Party. And those are groups that across the population have expressed more hesitancy about the vaccine. And so I think what you're really seeing is personal trumping perhaps the professional or scientific in terms of their judgment as to whether they want to take the vaccine. Where we're really going to see bigger issues in terms of vaccine rollout is what we're calling phase 1B in the United States, which is where you start to get into people who are what we call essential workers or really critical infrastructure workers, where you get into the elderly, people over the age of 65, and people with chronic medical conditions. And there we certainly have a supply problem right now. We also have a massive distribution problem. So looking at each of those groups independently, so the critical infrastructure workers, who are those people? How do you identify those people? Those groups are going to be different from state to state. And then how do you certify that they are indeed eligible? And so that's one group that's going to be challenging to figure out how to target. Then you have the people over 65. There, your challenges are that they may not be as mobile. They may not be able to get to a clinic or a hospital or a mass vaccination site as easily. And then you have people with chronic medical conditions who also have, again, some of these same mobility challenges. So, I think we have to address vaccine rollout in terms of what is the real bottleneck. So what you're trying to do is message about vaccine hesitancy when your real bottleneck is how do you get somebody who is wheelchair bound to a vaccination site? Your solutions are going to be off the mark. So I think those are some of the key things that I would highlight as we think through this. Speaking in terms of my advisory board role, some of the things we have debated is the role, for example, of the Defense Production Act, with respect, for example, to the raw ingredients that go into producing vaccines. But at this stage, that really does not seem likely that that's going to be necessary, given where we are in terms of supply versus distribution and demand. So I'll leave it there, I think, but just to provide that framework of how to think about vaccine rollout, again, is supply, distribution, and demand.
Since your predictive abilities have been so good in the past, that a lot of these kinks, at least in the early phases, will get worked out. I'm certainly hoping they will. Dr. Wen, can I turn the virtual space over to you now?
Absolutely. So thank you, first of all, Aaron, for the invitation for convening this conversation. I'm very glad to be joining Dr. Gounder and Dr. Van Kerkhove in this important conversation. And I want to appreciate what Dr. Gounder just said, because I think so much of how we should be moving forward in this response, it's not about blame and about figuring out who exactly should be, where the problem was, because somebody needs to be blamed for this, but rather looking forward and saying, now we need to identify exactly where the problems are, where the barriers are, where the bottlenecks are, and let's work to solve these problems, both short-term and long-term. And I want to focus my comments more generally on what has gone wrong in our pandemic response, not so much as a postmortem to figure out exactly what happened, again, to assign responsibility, but rather what is it that we could be doing moving forward. So I would say there are three areas. The first is the need for us to have a coordinated response, a national mobilization and not a piecemeal approach, which unfortunately is, and I'm speaking from the US context here, is much of what we have seen. We have seen this with testing. We have seen this with the rollout of PPE and frontline workers not having masks, gowns, and other PPE. And now, unfortunately, we're also seeing this in the initial vaccine rollout, that we simply, as Dr. Gounder very well laid out, simply have not been able to get out the doses of the vaccines that we have, which I just think is a profound tragedy, to be in a situation where there are thousands of people dying every day. We're now nearly at 4,000 people dying in the US every day, but we're unable to get out millions of doses that are in freezers, and there's potential wastage that's occurring. And I think, again, this is not about blame, but about saying we know this is a partnership between local, state, federal government, but there is very much a role for the federal government here. The role is not just to say, we wash our hands once we distribute the vaccines to the states. It's actively setting targets, asking the states, what is it that you need in order for us to accomplish these targets, trying to streamline processes that can be best done on the national level. And I hope that that is what the Biden team coming in will be doing, looking to see this as a wartime effort that requires a wartime mobilization, which is a national effort. Second point is that we've also seen in this pandemic thus far, the danger of misinformation and disinformation, including this unfortunate and extremely harmful narrative of somehow pitting public health versus other things, like public health versus the economy, public health versus schools, rather than seeing public health as actually essential to having the economy or having schools be coming back and reopening safely. And there was, and Aaron had initially prefaced this conversation with that about trust. And we know that public health depends on public trust. Also, that once that trust is broken and eroded, it's very difficult to get back. And I actually think that that's going to be many of our leaders' biggest challenge in moving forward. How do we overcome this disinformation campaign and really reestablish public trust? Third point is about how this pandemic has unmasked underlying problems. These issues that we're seeing now with lack of investment in public health, for example, they're not new. We in public health have known about them for many years. The problems of health disparities also is not something that COVID has somehow created, but we are seeing now what happens when there is chronic lack of focus in these key areas. And I do hope in moving forward that there will be renewed attention to these issues, that whatever it is that we're designing, whether it's vaccine rollout or any other policies about worker protections or anything else, that we're focused critically on the issue of equity, but also that we're not losing the needed attention that is long overdue on social determinants of health, on strengthening our public health infrastructure, not only to build back and prevent the next pandemic if and when that occurs, but also so that we have a more just and equitable and healthier future moving forward. Thank you.
Thank you. You had a terrific piece in the Washington Post earlier this week or the end of last, and you had some really helpful suggestions, and I want to come back to a couple of them during their Q&A. So, Dr. Van Kerkhove, can I turn the virtual space over to you now.
Sure. Thanks so much for having me on the panel. And it's really a pleasure to be with Dr. Gounder, Dr. Wen. I've seen you guys a lot on television these days, and it's really nice to share this space with you. Thank you for everything that you are doing. And Erin, thank you for organizing this. I think from my perspective, and I'm coming from the World Health Organization, so I'm thinking on a global level. Vaccines, the ability for the world to have come together to develop safe and effective vaccines, multiple vaccines, a year after we first became aware of a cluster of pneumonia of unknown etiology from China is astounding. It's an incredible feat in terms of science and the collective work that scientists have been working on. It didn't start in January 2020. It began from years of collaboration and work on SARS coronavirus, on MERS coronavirus, with investments that were put in place because the world knew that a high threat respiratory pathogen beyond influenza was always a threat. This was one of our disease X that we considered as a potential to be an epidemic or a pandemic. And so there was investment in that work, in that area, in that space, to think through that we would need diagnostics, therapeutics, and vaccines for coronaviruses. We were using MERS coronavirus. Little did we know that it would be a brand new coronavirus in the beginning at the end of 2019 and early 2020. But I think from our perspective, what we need are multiple vaccines, multiple safe and effective vaccines that can be produced around the world so that we could have production capacities to be distributed at different temperatures under different types of conditions. And so that supply can reach the world's population. Our goal as the World Health Organization with our partners and part of our COVAX facility is to ensure that we have vaccines and vaccination that reach those who need it most in every country, not only vaccines for everyone in a few countries. This is a massive goal of ours, and it goes beyond the rhetoric. It goes beyond the words and commitments. We have to follow through. And it's about the fair allocation of this. And so we work with our SAGE group to prioritize who should receive these vaccines first, which is in line with what you've heard previously. But we need to make sure that reaches all countries. And vaccines are different than vaccination, as you know. Actually producing the vaccines and having vaccines and vaccination into someone's arm are completely different things. To hear that we're at a point now where there's wastage is heartbreaking to me. I understand the reasons for this, and it is incredibly difficult to plan the rollout and to make sure that you have the people to do this who are incredibly busy dealing with patients, dealing with primary care and secondary care and tertiary care and home care and long-term care. It's another thing to make sure that we get those vaccines in the arms of those individuals. But I would like to highlight that vaccination is one aspect of control of COVID. It is not a silver bullet. It will not end this pandemic alone. And given that even if vaccine rollout was perfect, it would take time to vaccinate the amount of people that we would need to reduce not only morbidity and mortality, but to reduce transmission, to actually have an impact of preventing infections so that we would see a reduction in transmission. We have tools now, these non-pharmaceutical interventions, these public health measures that you hear WHO speak about repeatedly, and I have heard Dr. Gounder, Dr. Wen speak about repeatedly, that we can do and must continue to do now. One of the things we will be spending a lot of time on, in the early months of 2021 is really understanding the barriers to compliance. Why aren't people wearing masks? Why aren't people physical distancing? Arguably right now, one of the most important things you can do is physical distance. We have seen over the last several weeks with the holiday period, a lot of travel, a lot of mixing. If you consider how many contacts you had while you were isolating and really restricting your movement compared to what you did over the holiday period, we could argue that many people increased the number of people that they came in contact with. That increases risk, and that will have a profound impact on transmission, hospitalizations, ICU, and mortality in the first few months of this year. But we know what works in terms of physical distancing, mask wearing, hand hygiene, avoiding crowded spaces, opening a window, all of these measures, staying home if you're unwell. And it's a comprehensive approach. It's not one measure is enough. Masks alone are not enough. Hand hygiene is not enough. It has to be all of it together. And this public health infrastructure that has to be used are what other countries which have controlled COVID have used as their foundation to show that this virus can be brought to its knees even without vaccination. Vaccines are a powerful tool and vaccinations are a powerful tool, and I'm so grateful we have them. They will help us end this pandemic. But it's that public health infrastructure. It's about community-based workers, active case finding, cluster investigation, isolating cases. Arguably, what we saw across Asia, across the Pacific, in many countries in Africa, isolation of cases outside of the home, quarantining of contacts for 14 days, making sure that you prevent the virus, don't give it an opportunity to spread to somebody else. These break chains of transmission. That's easy for me to say. People need to be supported in doing so. So we need strong leadership to be able to do that. And I come back to the last point, we need not only good communication, we need open, honest, regular communication that points out what we know, it points out what we don't know, but importantly, it points out what we're doing to figure this out. It's not enough to say, we don't know yet. It's important to say, we've got the people who are on this, we're on it. And we're working really hard to get the answers to this. And those answers will feed into our response. We will course correct if necessary. That's not a weakness, that's a strength. And so if we are able to be open and honest about that, to be aggressive in our approach, to be comprehensive in our approach, to make sure that we engage, enable, and empower our communities so that they're part of this fight with us. We have, if you use your wartime metaphor, we have an entire army of people that help fight against this pandemic. And that's really what we need. This infodemic that we are dealing with information, we're just not meant to deal with this much information coming to us all the time. And the willful misuse of some of that information and disinformation has really been damaging. I think none of us would argue that we should let science lead the way and let data lead our approach. But we really are fighting against some very powerful forces that we have to figure out how to work through. And I think all of us are doing our best to try to figure out how we tackle this. And then we just need to hang in there. We need to be really focused. We need everybody to do everything that they can while vaccines are being rolled out to protect themselves and their loved ones. If it's not enough to do it for yourself, do it for your loved ones. Protect yourself and protect your loved ones. Because there is still so much that we can do as these vaccines are rolled out globally.
Dr. Van Kerkhove, thank you so much for that. I want to pick up on one of the main points you made. I want to read to the three of you this morning's coronavirus update from the New York Times. The numbers continue to climb. The case counts too fast. The vaccination's not fast enough. Most days since early December, the U.S. has added more than 200,000 new COVID infections. 4 states, among them Rhode Island, Tennessee, and Oklahoma, have all reported cases at extraordinarily high levels. In the 4th, as we know, California, more than 240,000 cases have been reported in the LA area in just 2 weeks. With higher caseloads have come more deaths. The 7-day average is above 2,600 a day. And on Wednesday, Pennsylvania and Oklahoma reported single-day records for deaths. And the variant, the mutation that is surging in Britain, has the potential to explode in the U.S. in the next few weeks. Experts warn that the country is ill-equipped to track it. I want to get at this whole notion of the relationship between this surging disease burden and the issue of vaccination. Dr. Van Kerkhove, your point, I think, supports the question I was going to ask you, the three of you, which is this. Is it still the case that the biggest factor determining how many people die from this virus isn't likely to be the effectiveness of vaccines or even the speed of the rollout, but reducing spread through mask wearing, social distancing, and relieving pressure on healthcare systems? The assumption is that these efforts can cut caseloads and, by extension, deaths faster than mass vaccination. That would basically mean that everything the three of you have been advocating, and Dr. Fauci and anyone else who's involved in this, The basic public health measures aren't discretionary or optional. They're critically important as part of a comprehensive strategy to beat COVID, or at least in 2021, for us to say we are on the way to getting control of this virus. Mm-hmm. And the question is, I guess, why? Why haven't we been able, leadership from the top, and there's no point in reviewing the last 9 months of the administration's flaws and ineffectiveness. We have a new administration coming. I guess my question to the three of you, I'm going to start with Dr. Gounder. Could it be something within the political, social structure and character of this republic that essentially prevents the sort of comprehensive, lets everybody sign up and have great confidence in government in order to cooperate in beating the pandemic? Other societies, other countries that have a high public trust in government have done much better. South Korea, for example. So what is it, do you think, or what are the elements that have prevented these sorts of measures from being adopted in the greater percentage of the public? Dr. Gounder, any thoughts?
Yeah, I think there are a lot of ways to answer that question. Some of the most interesting conversations I've had over the last year have been with political psychologists who study, for example, how people approach politics in terms of their psychological and social orientations. And there are definitely strengths to some of these East Asian societies in terms of being a bit more collectivist and group oriented, which I think does facilitate people sacrificing on behalf of their community. There are strengths to the American independent, perhaps less respectful of authority in some ways. It does lead us to be much more creative, to think out of the box. So it's not that one of these is better than others, but it's rather that sometimes in certain situations, a more collectivist orientation is going to be helpful, in particular when your country is facing a major disaster where everybody needs to band together. And that could be a military attack, that could be a natural disaster, that could be an infectious disease like we're dealing with now. So I think that's one. I think two, this question of trust in government. People trust government when there is transparency, when there's good communication, but also importantly, when government does something to serve them. And I think this is where having economic and social safety nets, not only would that have supported people and made people more able to follow some of the public health guidance around social distancing and mask wearing and so on, in a sense, because we did not provide those same safety nets that countries in Asia and Europe did, for example, we really were forcing people to make very difficult choices about paying rent and putting food on the table versus abiding by public health guidance. So I think those safety nets are important for that reason, but also they do engender trust in the government. When you think about Medicare, that's one of the most popular government programs, and it's because it's providing a very concrete service to all Americans over the age of 65. And I think we do need to reconsider what is the role of government in terms of providing public service to all of its people. So I think the final thing that I would say from a governmental perspective that has made it difficult here is that we are a federation of states. And so that does make for a patchwork approach and certainly a less coordinated response. And really much of the action is happening at the state and local level. And the role of the federal government is to help support it with funding, to support that with technical assistance, and to provide an overall overarching plan for that. And we've really had failure at the national leadership level, but also at the level of lack of coordination of the states and lack of funding for the states to do the work that they need to be doing.
It raises the issue of federalism, which has proven to be both a virtue and a liability in this particular situation, but it's a reality of American political culture. Dr. Wen, any thoughts, particularly perhaps from your experience as Baltimore's healthcare commissioner, with respect to how difficult it is to get people to buy on to a sort of public health program?
Yeah, I mean, I'm certainly happy to comment on this, and I also just wanted to make a comment too about the federalism, the divide between local, state, federal government. When I ran the Baltimore City Health Department, I was very proud of the fact that we had a well-running health department, and we on the local level knew the needs of our community the best. And for the federal government to come in and say, you have to do things in a certain way, or even for states to come in and say, you've got to do it this way, the same as the rest of the state, when the needs of Baltimore City are very different from many rural communities in the Eastern Shore, as an example. I mean, I would have really said that's not the right role of state and federal government. So I do very much believe in local autonomy and local control. That said, that doesn't mean that there isn't a role of the federal government. There is a role for federal guidance. For example, you can't have every local and state health department be trying to interpret hundreds of scientific studies on their own. There's a role for the CDC, for the World Health Organization, et cetera, to provide that kind of national leadership and guidance, that framework. And I think that that's maybe where some of this misunderstanding has been. It's not just leave everybody to do their own thing, but rather it's we need to provide on the federal, international even level, general guidelines, support, then that will then empower locals to do their work and tailor those guidelines to their local communities. And then the locals should then be feeding back to the federal government, what is it that we need in order to achieve these targets that you have set? And I think that type of partnership is really what's been missing in our approach of saying, basically, let's just leave it all to locals and states to run this response. All right, let me get to your question. An excellent one about how difficult this response is. Everything that we're asking people to do in public health basically is really hard. And Dr. Van Kerkhove, I think, had mentioned very well all these non-pharmaceutical interventions that are really critical for us to reduce the death toll, reduce the spread of infections, especially with the new variant. I mean, all these things that we need to still be doing, but it's really hard. Even at the best of times, even if we had consistent, clear messaging through every level of government, where our public health officials were aligned with our political leaders, even if everyone were saying the same thing. And I certainly agree with what Dr. Gounder said. I think even if we need the right social supports. You can't be telling somebody to quarantine and stay off from work if they're afraid they're going to lose their job. And how is somebody going to quarantine if they live in a house with 10 other people and they can't literally quarantine and keep themselves from interacting with others? So we need those social supports too. But even if we had the ideal messaging and the ideal supports, we're still asking people to do things that are different, that are uncomfortable, that are not what they are used to. That's why those other supports and messaging are so critical. But I'm usually an optimist, but this is not going to sound like a very optimistic comment. I think at this point for the US, the vaccine is our last and best hope. I do not have a lot of hope that even with President Biden coming in and a lot of, hopefully better alignment for messaging and social supports, I don't have a lot of hope that we're going to convince the majority of the American people, or the vast majority of the American people, to not be with their friends and family, to keep up social distancing, to now adopt masking when masking has become such a divisive political issue. That's why I am putting I wish it were not this way. But at this point, I think we do need to put our eggs in the vaccine basket. And that's why I think the vaccine rollout and ensuring a speedy, efficient rollout is so critical, because I just don't think that the American people has the patience at this point to do these hard things. I think we are a culture that looks for the quick fix. We want the pill for every pain. And we have not succeeded thus far in containing the pandemic. And so we need to get the vaccine into arms, or else there's going to be far more destruction and preventable deaths in the years to come.
Yeah, that's a chilling observation, because it means there's going to be a lot more darkness in this country and death before a corner is turned. Dr. Van Kerkhove, you raised this issue, and I think it's critically important. Any further thoughts on the problem of trying to create normative standards that people are, because you've had perspective with respect to other countries in the world, who have clearly, no one handled this thing perfectly. Maybe Taiwan, that they've created a
No one
degree
is
of
perfect.
normalcy.
Yeah.
Nobody's perfect. So
Nobody's perfect.
what are the elements that others have, other countries seem to have had high social trust experience with these sorts of diseases, that might provide some clues as to what more we could do? I suspect it's going to be limited.
Yeah, well, I mean, you mentioned South Korea, and you mentioned there are many countries that have dealt with other infectious diseases like SARS coronavirus in 2003, like MERS coronavirus across the Middle East. And I'm the MERS coronavirus focal point before this. And the experience that countries have had with dealing with SARS and with MERS. And if you look across Africa with Ebola, with yellow fever, with meningitis, with cholera, with monkeypox, that dealing with infectious diseases and those outbreaks, the MERS coronavirus outbreak in 2015 in South Korea, there were 186 cases and 39 deaths. And there was an $8 billion economic impact on that outbreak. That outbreak in Korea forced the country to reassess the way that it deals with infectious diseases. Its entire infrastructure around medical care, around workforce and epidemiology, around collection of data and sharing of that data, law, public health law, communication, even the way the organizations were structured. When there's an event, for example, Korea CDC, is elevated to a level where they can take decisions. I mean, I think what is really quite critical in those types of situations is many countries have had a trauma of dealing with something like this before. But what they've done is they've used that trauma to change. And we haven't seen that in many high income countries. We may see that now, and I am very hopeful that we will see that now. We have seen countries across Africa, across the Mekong Delta region in Asia, build up community health workers, for example, people that can go door to door. These are the individuals that check on others, that do contact tracing, that do the management of people who are cared for at home, provide food, provide that medical contact. And that trauma has led to change. And I think we will see some differences following this pandemic. I hope we do, because, we have to. And Dr. Wen, your comments, and Dr. Gounder, your comments about the federal system, we have to have very strong national plans, but they must be implemented at the local level. They must be agile and tailored to the local needs and the local level. And those will change as the epidemiology changes, as the capacities change, because we're not in the same position we were in a year ago. We know so much more now. We develop the guidance, CDC develops the guidance, but it's guidance. It needs to be adapted and tailored at the local level and implemented at the local level. And that's really critical. But Dr. Wen, I just want to come back to a comment that you say about the vaccine. And I agree with you that we have to use vaccines appropriately and strategically and wisely. But I hope that in America, that Americans can still do necessary measures at an individual level to keep themselves safe as much as they can. Because if they don't, we will continue to see overburdened health systems. And this is true in every country. And more people will die. And these are unnecessary deaths. So I hope that that is a motivation to individuals. And I agree with you, this is hard. None of this is easy, and it's confusing, and we're all fed up with this, right? We want this to be done and over and back to normal. Normal includes physical distancing. It will include thinking through our day and taking all of these little collective decisions to try to keep ourselves and our loved ones safe. And it's going to be hard for a while. But I am hopeful, that through this year, towards the end of this year into 2022, we will see a difference across the world. But I do hope what is left behind is a stronger infrastructure to be able to deal with this at the primary care level, at a community level, so that when this happens again, and I think unfortunately it will, we will do much better. We will be much faster. We will be able to really kickstart our systems so that we do better and more aggressively in the beginning.
Thank you so much. Let's transition now for a few minutes to talk about vaccination. The difference between vaccines and vaccination. supply-demand distribution. Those were Dr. Gounder's key points. Dr. Wen, again, and I'd recommend it, had a piece in the Post which offers a handful of practical advice as to how we could create more efficient strategy for a successful vaccine. Among them, other than establishing targets and helping locales meet them, is the notion of recruiting an army of vaccinators. And the notion of army is a conscious and willful choice, because it seems to me that, nothing short, and I suspect this isn't going to happen, but nothing short of a D-Day-like comprehensive enterprise, Defense Production Act, vaccination tents, an infrastructure of vaccinators. Am I dreaming here, or are we capable of creating a national strategy administered at the local level that actually has coherence and cohesion and could actually work? And that I think, it's hard for me to envision. Maybe I'm a prisoner of the last year or so and watching federal government response to this. But I also don't want to overload the Biden administration with unrealistic expectations. So, Dr. Wen, any thoughts? It was your piece, and I think it's a very useful point of departure. Are we really talking about an army of vaccinators, tents at local high schools, football stadiums, rollout at Walgreens and CVS's with some measure of coherence, notification, priority set, people know what to do, they receive emails? Is that really what is necessary? Or are we talking about something quite different?
Well, to answer your question directly, is it really what's necessary? In one word, yes. And you had also asked another question about, is this something that we can do as state, local, federal government? Not only is it something that we can do, it is what the American people should expect us to do. And it also is the baseline of what we should be able to do. This is not a grand goal that somehow is too difficult to achieve. This is the baseline of what each of us should be able to do. Vaccination programs, that's the bread and butter of local public health. Other countries are able to do this. The US has been able to do this in the past, in many decades ago, way before we had the type of resources and technological scientific capabilities that we have here. If we're unable to do this, it's not because of lack of science, it's not because of lack of resources, it's lack of willpower and lack of coordination. And I do not believe that that's what the American people want to be known for. We also have the ability on the local and state level to do this. Local and state health departments know how to set up vaccination programs, but it can't be done piecemeal. You can't have 50 different programs that look at who is licensed to give vaccinations. You can't have local health departments, as currently is the case, using SurveyMonkey and Eventbrite and random ways of scheduling people. That just it's totally inefficient. It creates many bottlenecks, and it's just not the right way to be launching this type of campaign. And so I wrote this op-ed in part to say we need, and I used the army and the wartime metaphors very deliberately, as you noted, because this needs to be an all hands on deck 24/7, not only whole of government, but whole of society approach. And I actually believe that in mobilizing an approach like that to do the vaccine rollout, that is also how we're going to get people to be thinking about coronavirus every day. And therefore, to Dr. Van Kerkhove's point, to also then be thinking about what are the other measures that we can be doing in the meantime while we're getting this program up and going. But this needs to be top of mind for everyone every single day. That type of urgency needs to be conveyed from the federal government. They then need to be helping local and state health officials to be doing their work, as well as to be streamlining all these other processes so that we don't have such incredible inefficiencies and piecemeal approaches. But yes, to your direct question, Aaron, I absolutely see this. Yes, there should be a role for Walgreens and CVS and private hospitals and clinics to be doing this, but we also need to have stadiums that are the places for people to be vaccinated every single day, all across the country, 24/7, and the ability for us to distribute the vaccine should no longer be the limiting factor here.
Dr. Gounder, not to push you on the forthcoming Biden administration's approach to this, But let me ask you a practical question. If the priority already were nursing homes and healthcare workers, wouldn't you have anticipated that these two groups would have been, since nursing homes are sedentary, the vaccine would have to come to them. Healthcare workers, presumably through hospitals, would have an infrastructure, although what you do about all of the docs and the PAs and all of their assistants who are not affiliated with hospitals, how do you rope them in? You'd think that the first phase of this would have gone relatively smoothly, and yet you yourself identified a resistance among healthcare workers, which is a fascinating insight as to why they would be, you would think they would be only too willing to sign up given their vulnerabilities.
Yeah, so I think phase 1A, so let's break that down. You have the long-term care facilities. A couple things happened to slow this rollout down. One is that assisted living facilities were added to that list very late in the game, and that essentially tripled the number of facilities to which they had to, the retail pharmacies had to roll out vaccination. So that's a big ask at the 11th hour. So I think that is part of what we're seeing the fallout from. It's also the holidays, and many of the facilities were frankly not prepared to have the retail pharmacies come on site to do the vaccination. Part of what they need to do is make rosters of who are the people that need to be vaccinated, to organize things on site. And some of the facilities simply were not prepared. And some just didn't want to take this on over the holidays. So I think some of that is going to straighten itself out towards the end of January. And then with respect to healthcare workers, I do think if they are communities of color, if they are from the right wing of the Republican Party, those are two of the most hesitant groups about vaccination. Those other personal characteristics may well override their professional characteristics. And so I think that is where you're seeing some hesitancy. There are also just some logistical issues within hospitals. And I think unfortunately, some have been well-meaning, trying to create even further stratification of priority within healthcare workers. So for example, only healthcare workers who are over the age of 60 in an ICU or in an emergency department, and then so stratifying from there. The problem is that when you do that, you're going to slow down your vaccination even more. And so let's just take the ICU. You can't have everybody in the ICU get vaccinated on the same day. They work in different shifts. You don't want, half of your ICU staff calling out sick the next day because they've had a low-grade fever after vaccination. So I think we need to think about, how we're actually getting in our own way in how we do this. So I think that's, some of the comments I would have about the phase 1A. And hopefully we do learn from some of these mistakes and accelerate as we move into other populations. I do think there are a couple other things I'd like to highlight. And I 100% agree with Leana about the approach that she's outlining. I think having state and local public health departments run mass vaccination sites would make a lot of sense. It's a lot easier to do, I can say, having worked in a number of countries in sub-Saharan Africa, as well as in the US, it's a lot easier to do overseas. We are a highly regulated system here. We have a bloated healthcare insurance bureaucracy that makes it very difficult to do some of these things. We have these expressions about, to use the jargon, task shifting or working to the top of your license. So the idea being, let's say you have a dentist or a veterinarian who could give a vaccination. In other countries, we would enlist them to do that. Here, it actually becomes very complicated because of our bureaucracy and our regulations. And these are things that are not partisan issues that should have been addressed over the last year. The federal government should have been working with states around things like scope of work to say, we're going to loosen up, who can give a vaccination. If you're a veterinarian, we're going to make it possible for you to also vaccinate humans. So that would be an important one, and it's a no-brainer. That should have been for the last year and was not. State licensing is also a major obstacle. We license medical providers, healthcare providers on a state-by-state basis. So me in New York City, I cannot go to Newark, New Jersey, which is less than an hour away, to help there on the front lines because I do not have a New Jersey license. And that's one thing that I really would like to see come out of this is more logical regulations that allow for more flexibility in the setting of a crisis like this. I also think, Leana pointed out, we can't be using things like Eventbrite and SurveyMonkey to, for our scheduling and registration systems. This is an area where we really do need a national system that would support public health departments, local and state health departments across the country to do things like registration and scheduling, to be able to call people back for their second dose of vaccination, to monitor side effects. This is not something that's efficiently done on a piecemeal basis at each and every state and local health department. And this is also something that costs money. And unfortunately, many of these health departments have not had that kind of tech investment. Some I've seen are still using DOS-based systems for some of their data capture. That is shameful that we're in that situation. And then finally, billing. And this, I think, points to the fragmented nature of how we deliver services in this country. There are literally thousands of insurance plans in this country. And if state and local health departments have to capture the money that they could get from private insurers, they need to have a billing system to do that. So if they don't have such a system, they're leaving a ton of money on the table. But then to have billing systems, you have to spend money hiring all those people, creating that bureaucracy, having the IT systems to do that. And we simply don't have that. So, I think we're going to have to think very carefully about how is our bureaucracy structured? How do we fund these services? And how should that change in the future?
Thank you. We've got about 8 or 9 minutes left. But I do want to, and I have a couple more big picture questions for the three of you, but I want to ask a specific question on the variant or the mutation. How serious an issue is this? I mean, what's the media coverage, at least the beginning, has been, it's not a big deal. There are mutations and variances in viruses all the time. The vaccines will be able to deal with this. Apart from the issue that more infection, even if this variant is more contagious, you're going to have more stress on the hospital systems and more people conceivably going to die. But how big a problem is this? Dr. Van Kerkhove, do you want to?
I can certainly start, and I'm sure there will be more comments on this. But yes, there are mutations all the time. But every single one of these mutations needs to be assessed to determine if they're important or not. Most of them are not important in terms of the virus's behavior and the way that it spreads, the disease it causes, and its impact on diagnostics, therapeutics, and vaccines. But there may be some that will cause some changes. There are 2 variants you need to be aware of. There is one that was identified in the United Kingdom, and it's called a variant of concern 2020-1201. And there's a second one that's separate to this that emerged around the same time from South Africa, and it's called the 501Y V2 variant. These are separate variants, and these variants are different because they're more than one mutation. There's a number of mutations that have been identified in each of these variants that arose separately. In the UK, for example, this variant of concern is associated with increased transmissibility. And the way that they identified this is in Southeast England, they noticed that there was increasing transmission in areas where they had interventions in place. They were in their tier 2, tier 3 lockdown system, and cases were increasing. And so they looked to see why. They had been having conversations with us through our virus evolution working group, because we set up an evolution working group from the beginning because viruses change, but we need a system in place to robustly assess which ones are important, why, what studies need to be done, linking with the labs, linking with the researchers, linking with the vaccine manufacturers to make sure that those studies are done consistently, openly. And they were discussing with us, and we had a colleague from South Africa saying, we have found a variant that has this one mutation, 501Y, in the spike protein. which is concerning because if it's in that part of the virus, it could impact the virus's ability to develop neutralizing antibodies, diagnostics. There may be some impacts. And so your alarm raises a little bit there when you hear that. But what we're doing so the UK has a variant that can transmit more easily.
Right.
And its reproduction number has increased from 1.1 to about 1.5, 1.7. Now that's not good. You don't want any virus that has a reproduction number that increases, but it hasn't gone from 1 to 10 or 1 to 20. I'm not trying to downplay it at all. But I do think it's important to say that in the beginning of this pandemic, the natural reproduction number of this virus, the SARS-CoV-2 virus, is anywhere between 2.5 and 3.5. And the world has worked incredibly hard to get that below 1, which means the virus won't take off. So we don't want to see any viruses that emerge that have increased transmissibility. The South African variant is being investigated as well to look at transmissibility. Those studies are currently underway. Both viruses do not seem to appear to cause different disease profile or severity as measured by hospitalization rates or by mortality. So that's good news. But if a virus can spread more easily, then you can have more infections. And so that's not what we want. But we don't think so far, based on the data that we've seen, that there's an impact on the vaccines. But it just means we have to work that much harder. But to answer your direct question, we do not want to see virus variants. And the more this virus spreads, and this is another reason why we have to do everything we can, the more this virus spreads, the more it's going to mutate, the more it's going to change. And the hypothesis for these two variants is that normally a virus changes at a certain rate. And luckily, SARS-CoV-2 changes at a lower rate than other viruses, so it's slower to change. But the hypothesis for these two variants is that they emerged in individuals who were perhaps immunocompromised, and that the virus was changing as it was replicating in the immunocompromised patient, and then there was a late stage transmission. That could be happening elsewhere. And if we do not have the surveillance systems in place to be able to do the sequencing, to share those sequencing and platforms like GISAID and others, to do the phylogenetic analysis, to actually evaluate this, to have the collaborations in place, we will miss these variants and they will spread. So we're playing a very, very dangerous game right now with this virus.
Yeah.
So everything that we can do to prevent as many infections as we can with whatever tool you have at your disposal, we should do. And I do appreciate the wartime analogy here of like all coming together and saying, we can do this. I mean, that's what I saw across Asia. I was part of the team that went to China in February. There was a war-like time. There were billboards everywhere. We can do this. Every single person I met knew what they had to do. And we've seen this in Korea. We've seen this in Japan. We've seen this in Cambodia. We've seen this in Australia and New Zealand and Nigeria and on and on. We need that in the United States as well. And that can be done, not to minimize the incredible challenges that will be seen, because it will get worse before it gets better, but we can do this.
Thank you. We only have a couple minutes left, and I do want to ask the final question in terms of preparation. We were warned. I mean, the last 5 national threat assessments warned, classified, but they've been declassified, of a respiratory virus that could kill thousands of Americans and destroy an economy. You had SARS, you had H1N1, you had MERS, you had Ebola, you had Zika, and we seem to have basically gone to sleep. I made the point to you before that we need a new definition of homeland security. The threat, when it came not from white nationalist terror, which is a problem, or jihadi terror, which is a problem. It came from a virus, which altered life in America as we know it. So final question. How do you craft an international response when, in fact, national sovereignty, nations are sovereign, they guard their sovereignty, their information, their funds tenaciously? How do you strike the right balance in terms of an international response to be ready for this the next time? Dr. Wen, could I ask you briefly? It's a huge question. I'm sorry.
It's a huge question.
and I am sorry that I'm going to have to leave as soon as I answer, but it's been a delight and truly an honor to join you all in this conversation. I'll give a short answer to this, which is that I think it needs to begin with us convincing our own people within our country about the importance of addressing the domestic threat and tying the need to address the international threat to the domestic policies. Because for better or for worse, people do care about themselves and their own environments the most. And that's understandable. People care about their families, they care about their jobs, they care about their own livelihoods. And we need to be convincing people that investing in global health and global security also directly impacts our own well-being. And so I think making that case for domestic policy is the most critical. But thank you all for the opportunity.
Thank you so much for participating. Dr. Gounder, the last word to you.
Yeah, I would echo what Leana just said. I would also say that more broadly, we need to be making the case for public health, for people to understand what is the story of public health. Why is this important? You know, for example, if we had 9/11 happening every day in this country, which is essentially what we're having now with the number of deaths that we're seeing, people would not be having the discussion, oh, is it, our defense versus the economy? That would be a no-brainer. And I think we need to reframe our thinking in that respect. And the one other piece I would add is, one thing that we clearly should be doing is sharing data, sharing information, sharing our learnings, our surveillance, because it's really impossible to address this kind of crisis without that shared understanding.
Thank you so much. We could devote a whole nother session to this. I will thank Dr. Wen personally, but I want to just say to the two of you, this has been one of the richest, most comprehensive sessions we've ever had. And I want to thank you for your selflessness, your service, your unbelievable knowledge and authority. I mean, it's really impressive. I know there are more of you, but we need people like you. And again, thank you so much for participating. And to our audience, thank you as well. We went over a minute or two, and looking forward to the next Carnegie Connect. Stay safe and stay healthy.
Thank you so much.
Thank you.